Donovan, what's happening, brother?
Good to see you, Alexander.
It turns out we're like, birds of the same flock. I've kind of found out here in this early
Yeah,
conversation.
yeah, we're
Um,
out there.
yeah. So why don't you tell us a little bit about yourself, who you are, and what you've been up to over the last couple of years?
Sure. So I'm Donovan Pyle. I'm the CEO of Health Compass Consulting. We're a management consulting firm that specializes in helping mid-sized businesses finance and procure healthcare more effectively for their employees. So
Mm.
very niche. Beyond that, I'm the author of a book that's coming out later this year called Fixing Healthcare: How Executives Can Save Their People, Their Business, and the Economy. And then I'm also a senior advisor at the Validation Institute up in Boston. It's great to be here with you today.
So, how did you get into the healthcare world? Did you start in healthcare, or you business owner and just kind of saw this?
Not at all. I was a my first career was in music. I was a full time musician up in Manhattan for 10 years.
Oh, what
Uh,
what what do you do?
I was playing drums, and if you were watching TV back in the mid 2000s, you definitely heard me on commercials for HBO, Chevy, Nike, Motorola. Remember Motorola?
Oh yeah. So you were like a commercial musician, like
Yeah, so funny enough, like all these commercials that we hear or see on TV, they all have music,
yeah,
and someone has to make that music. And
of
so
course.
I worked at a big, actually the largest commercial music house in New York City for a couple of years, and that was just an amazing experience. Yeah, beyond that, I've got credits with U2. I helped
Mm,
mix an album for them in 2009
all right.
and a number of other records. So yeah, it was a great run. I toured with a band. Lived in a van with four guys down by the river for a couple of years, um, and we got signed to EMI, and then EMI went bankrupt,
Mm,
and our debut album, never even got released. And I was
mm,
31 years old at the time, and I said, "It's been a great run, but I'm so sick of this lifestyle.
yeah.
Instead of going to bed at 6 a.m., I want to wake up at 6 a.m."
Mhm.
And what's the furthest thing from the music business that I could get into? Well, I don't know anything about insurance, but it sounds boring as hell. And
Yep, yep.
I just want to I want a boring life.
That's
That's what
hilarious.
I was really looking for. Yeah, worked my way up through. Somehow convinced some folks at Chubb to hire me,
Mm,
and benefits brokers were my customers. And I saw some opportunities. I was like, man, why aren't these brokers, really doing better things for their customers? And so that led me to start a consulting firm, and it's a long story, but happy to answer questions.
so what were you seeing when you were at Chubb that you said you didn't think people were doing the things that were right by their customers?
Okay, I think it's important to just understand the landscape a little bit, because a lot of people, consumers and business owners, don't necessarily understand the landscape.
Mhm.
So just to level set for your audience, about 50% of Americans get their healthcare benefits through their employer, which
Yep.
you're a business owner, you're subject to this.
Mhm.
So 164 million Americans get their healthcare benefits through their employer.
Got it.
And
Yep.
businesses and their employees spend about $1.3 trillion a year on healthcare.
Mm,
And here's the amazing thing: about 25% of that $1.3 trillion, about $300 billion of that is complete waste.
mm.
Okay. And I'll get into why that is in a second. But if you understand the supply chain, most businesses they don't understand they have no technical expertise as far as healthcare financing and procurement goes. They know nothing
Yeah.
about it, right? I mean,
Mhm.
you didn't start your business so that you could provide healthcare to your employees. That's not
Mm.
why you did it.
No, I was gonna ask if you know any of the history about why businesses got so intertwined with healthcare, because it always, for me, has seemed like you're just,
Hmm.
like, putting 2 things together that don't like, 401k, that one kinda makes sense to me. "Hey, I'm already paying you something. Let's just agree we'll sock a little bit away, and that'll be good for you in the future." But how did health do you know how healthcare got, like, intertwined with businesses?
Oh, this is such a great question. So, and I actually cover this history in this one of the chapters in my book. Um, so, okay, so let's back up a little bit more. Let's go back to 1900. In the
'Kay.
year 1900, the average American spent more on cosmetics than they did on healthcare.
Yeah, a follow-up question would be, when did health insurance even, like, come into play, right? That's when
Okay,
the
well,
doctor would come to your house, right?
yeah, exactly. And the reason that they spent so little on healthcare is that there weren't doctors weren't really able to cure anything back then.
Right.
There was very little they could actually do. So the average American spent $5 a year on healthcare. That was about 1% of their income on
Mm,
average. And so what happened was, through the 1910s and the 1920s, as medical advancements came to the fore, well, the cost of and these hospitals were actually started to be able to actually cure people.
mhm,
This is a new concept. I mean, back in the
mm,
day, hospitals were basically a place where the indigent went to go in their final days just to
mm,
be comfortable.
mm.
And so the idea of having clean hospitals that could actually cure things was a novel idea.
Well, and
And so, but
also
yeah, go ahead.
not make your sickness worse, right?
Yes.
Like, that was a big thing with, like, the initial theory of germs is, like, the doctors just didn't believe that touching someone else's blood and then touching you, that was, like, a crazy idea. They're like, "That is stupid. We don't need to worry about." Like,
Yeah.
I heard this whole story about this doctor who originated this idea. They thought it was in the vents. They spent all this money, like, trying to, like, remedy the vents, and he was like, "No, you guys gotta wash your hands." And they,
Wash
like,
your hands.
ostracized him. Um, that that took a long time for doctors to eventually be like, "Oh, we actually should wash our hands." So,
Yeah, yeah, yeah. It's just amazing. So as you know, the training of doctors increased and improved, the cost basis for hospitals started to go up. And so while they were able to actually cure people for certain things, they were discovering that their patients couldn't actually afford to pay them. And this became a
mm,
big problem that was exacerbated um, through the Great Depression. And so
mm,
what happened was that in 1929, Baylor University Hospital in Dallas, Texas, said, you know what? What if we could convince a large employer to prepay for our services so that we could stabilize revenues? And people
stabilize
wouldn't,
their revenue, not necessarily,
yes,
yes. Yeah.
yes. And patients wouldn't be afraid to come in to our nice, clean hospital and use it.
So,
And so
like,
what
at
they,
that at
go ahead.
sorry to at that time, like, let's say that, okay, 2 situations. One, I come in and I've got, whatever, pneumonia, and they're gonna treat me in some way, shape, or form. Would they tell me, "Hey, it's gonna be $1,000," and then I could decide whether or not I could pay for it? Is that how that would go?
I think I don't think there was a consistent um, offer
I
on the
see.
table. I'm sure it was, much more market driven than it is today, where you
Yeah.
actually, today it's very hard to understand pricing, right?
Mhm.
But since it was all cash based back then, you got to assume that yes, there were those conversations that were happening more frequently than they do today. So yes, yes, okay. Here's what we think you need. Here's what the price is going to be. How much can you pay?
What
Right?
what what do you think they would do with an emergency situation? Like, I
I
walked
think
in and I got into a barroom brawl, and it's like, "Oh, we gotta do something."
yeah, yeah. So emergencies. I think that at that point you're basically just trying to get what you can.
I see.
I mean, but here's the interesting thing. I mean, most people think about emergencies a lot when they think about healthcare, but 85% of what we consume is actually scheduled. It lives on a calendar.
I
It's
believe that.
planned in advance.
Yeah.
So so yeah, I mean, it's just a fascinating. In fact, if you ever saw that show, The Nick, it's about a hospital in Lower Manhattan
Mm.
in the year 1900. Fascinating,
Mm.
really well
No,
done.
no, I never saw that. That sounds good,
You,
though.
you would love it. You would love it. So they were having this challenge, and so Baylor University actually partnered with Dallas Teachers Union,
Okay.
and they had I think maybe 5,000 employees, something like that. And they said, listen, for 50 cents per employee per month, your teachers can come to our nice clean hospital and deliver their babies.
Mm.
Okay. And so that program became the first Blue Cross plan.
Interesting.
Mhm.
Huh.
Now, here's the thing. In the next 10 years, all these other hospitals around the country saw the success of that program and said, hey, can you help us build Blue Cross plans in our region so we can stabilize our revenues as well? And so these hospitals, this is amazing. People don't realize this. Hospitals actually invested the money to create health insurance companies in the 1930s.
Mm. Mm.
So today we think that hospitals and health insurers have this, antagonistic type of relationship. They sit on opposite sides of the table, and every couple of years we see this like public fight in the newspapers about network contract rates and this kind of thing. It's all
Hmm.
smoke and mirrors. At the end of the day, they both benefit from rising prices.
Yes, that has always been my impression, that there's a lot of like finger pointing just to like deflect the blame, but behind the scenes, they're kind of like, it's kind of like you're selling a fight, It's like, oh, I'm gonna, but it's like,
Yes,
yeah, we're like we're okay with each other. We just,
right.
we're just doing the thing we have to do for business.
100%. So okay, so let's dive a little bit deeper into the supply chain. So you've got hospitals, you've got health insurers now. Health insurers at that time originally had in-house sales forces, right? They had salespeople knocking on doors,
Hmm.
right? Selling these individual policies, selling group policies to
Okay.
some employers, but it wasn't really a thing. So I'm getting around to answer your question. Um, when the federal minimum wage laws went into effect, and I think it was 1938,
Okay.
these health insurers said, you know what, this presents a financial risk to us because let's face it, like most sales forces, 80% of the people don't really sell anything. And so that creates a financial risk for us because we don't want to have to pay them a minimum wage for these people that don't actually sell anything.
I see.
So here's what they did. They flipped them and reclassified them as 1099 subcontractors.
Okay.
Okay.
I'm following.
Okay. So that's all good and fine, but it opened the door for now these independent contractors, salespeople, could not only they could sell that one insurer's products that they were selling, but they could also sell other insurance companies' products.
Got it.
And so this became the brokerage industry. This was the
Mm.
birth of the brokerage industry.
And were most people selling like health insurance and other types of car insurance, homeowners insurance, flood insurance, all that, or were they like picking and choosing different medical carriers to sell?
I think predominantly medical carriers. So by 1940, there were over 14 Blue Cross plans throughout the country, different Blue Crosses, different health insurers.
Different
And
health insurance throughout the country. What does
yep,
that mean? Like different state level programs?
yes,
Got it.
yeah,
And
yeah,
that's kind of a big thing in the health insurance industry, right? Is it's sort of state by state. I know almost nothing about this, but it's state managed. You can't cross over state lines. That's kind of what I've heard.
yeah. It's funny how that narrative like permeates the media. So certain types of plans, what are called fully insured plans, are mostly regulated at the state level.
Okay.
Whereas partially self-funded plans, level funded products are regulated predominantly at the federal level
Okay.
with some state oversight, a little bit.
Got it.
But yes, so basically you've got all these different health insurers, different companies that are selling products in their region. They've contracted with their hospitals, blah, blah, blah. Everything's fine and dandy. So at the end of the day, these independent brokers get paid to sell products. They are retail distribution for health insurance companies, and health insurers are distribution for hospitals. So hospitals, insurers, and brokers all benefit from rising prices.
Yep.
Brokers work on a commission basis, and they get paid bonuses by carriers,
Yep.
health
Yep.
insurers. Okay, so I'm going to answer your question now. that was just the setup for answering your question. Here
No,
we go.
that's great.
So why did employers get so intertwined in this healthcare business? Well, like so many government policies, there are unintended consequences.
Mm-hmm.
So back in the time of WW2, um, there was the Stabilization Act. because we had this huge labor shortage because, let's face it, I think we had 24 million Americans volunteer
Mm-hmm.
to go fight the Nazis. And so there was this huge inflation happening because the labor markets were so tight. So employers kept on throwing more money to get employees. They kept on increasing salaries, and that helped create fuel more inflation.
Mm-hmm. Oh
So the
yeah.
government, so the unions said, "Well, listen, if you want to freeze our wages, right?" And that's what they did through the Stabilization Act. They froze wages.
This was a government mandate to freeze wage increases.
Yes,
So instead of a minimum wage, they kind of had a maximum wage.
yes. Now
Well,
we've got a minimum wage and a maximum wage.
I think that you and I are going to probably approach this topic from the same direction in that the government intervention generally never solves the problem, or as you would say, it has unintended consequences.
Yeah, probably makes it worse.
Yes.
So what the unions negotiated during as part of the Stabilization Act was that they were going to carve out um, benefits from wages. Benefits are not considered compensation. So these employers, if they contributed towards benefits, they could do that. They could offer all kinds of benefits
Got it.
on a pre-tax basis. So there's a tax advantage benefit.
Okay.
And so, like you at your company, there's probably a number of benefits that you offer that are pre-tax. You offer them on a tax advantage basis.
Hmm.
Um, and so this really exacerbated and fueled the demand for group health insurance.
And
And
those
so,
unions were probably big organizations too. So
yes,
then when the healthcare company starts seeing, ooh, like a 3,000 person organization just signed on board, like we should go get some more of those, right?
absolutely. Wow, what a great leverage point. Instead of selling one policy at a time, now I can sell one policy to 3,000 people in your example. That's a huge leverage opportunity.
Makes sense. But
Yeah,
that
yeah,
was not in any way, shape, or form government mandated. It was just kind of an unintended consequence of the government situation. That was sort of a backdoor to paying your employees more.
100%,
Mm.
100%. So here we are, fast forward to today. 81% of businesses rely on brokers to help them maximize the return on their benefits investment. They don't know anything about benefits. HR people have virtually no training in benefits. God bless them, they have 100 other things they have to know about. Benefits is supposed to be one of them, but they have no training in it.
Mhm.
CFOs have no training in benefits whatsoever.
Right.
And yet, benefits, healthcare has become, in many cases, the second largest expense, and it's often the fastest growing financial risk on our P&L.
Hmm.
And one of the thesis for my book is that the reason why we're so bad at purchasing healthcare in this country is because the people that we rely on to help us purchase it effectively and manage our healthcare supply chain have no incentive to actually do that.
Mm. That makes sense. Yeah, it'd be like going to a car dealership and the car dealership knows that you don't understand cars at all and you don't know what should be $5,000 versus $50,000.
Exactly, because the salesperson works for the dealership, not for you.
Right, and it's I don't wanna say it's impossible, but it's virtually impossible, because I've tried this with our company. It's virtually impossible to go into the open market and, like, get a quote from, like, United or
Yeah.
Aetna or Anthem. They'll be like, "How big it" I tried this myself, and I don't remember which of those 3 I went to, but one of them, I went to them, and I was like, "I wanna get a quote," and they're like, "How big's your group?" And I was like, "It's like, I don't know." At that time, we probably had 30 employees, and only half of them were even on board. So,
Mhm.
it was like a 15-person group, and they're like, "Yeah, we're like, we can't quote that even."
Well, I love that you tried. I mean, I think that's great that you tried to go direct, and I think it's fantastic. So the analogy I like to use to describe the ludicrousy of this industry is that imagine if you hired a CPA who got paid by the IRS.
Okay.
How much more in taxes do you think you would end up paying
Right. Right.
in that scenario?
Yeah. Yeah, he'd be, "Oh, well, this is a little bit of a gray area. We gotta pay it." It's like, "Okay, I guess," you know?
Yeah,
Yeah, as opposed to the
especially
incentive
if
being the
right,
other way
especially if they
around.
got paid a percentage of the taxes that you owed.
Mhm.
Wow, you would definitely overpay. So my message to executives is that listen, many of the solutions that you need to solve your company's healthcare woes, to reduce the inflation rate of your health plan, to improve benefits and care for your people, many of those solutions are available in the market.
Mm.
But you will never see them so long as you are not getting unbiased advice.
Mm. Okay, maybe talk to me about all of the players that are involved in the process of getting healthcare, right? We talked about it
Mhm.
uh, just a second ago, but of course, there's a broker, there's a insurance company, there's the hospitals, there are these
Yeah.
pharmacies. I know something about these pharmacy benefit managers, which are
Oh,
apparently like evil. Can you maybe just like outline all of those for me, and then
100%. You are what you're describing is the healthcare supply chain. What's the vendor stack, right? So you've got hospitals, health insurers, brokers
okay,
that sit on this one side over here. They're on the supply side, and all the clinicians back there. That's all
yep,
the supply side.
got it.
Then on the demand side, you've got employers and patients and
Yep,
employees,
got it.
right? So supply and demand, great. Okay, employers ask their broker to basically conduct a service, which is procurement.
Mm-hmm.
That's basically what they ask them to do. Can you procure these products for us? Make it easy for us to understand what these things are, what they mean, and which one we should buy.
Yeah, it's a little bit like your finance broker, right? Like I've got my money, like I want to go invest it in something, and that's another situation where you know there's not a huge incentive for them to necessarily do the right things. A lot of times they probably could be selling you like higher commission type products, um,
Yeah,
and also I've said this to my friends a lot of times, like your broker's primary incentive is not to earn you a high return. It's to not lose all of your money and lose you as a client. Because, like, if the broker loses 20% of your money in year one, and even though you might have made 50% in year two, it's like you're going to leave. So it's like we
yeah.
might as well just make 6% per year, and I can keep this guy on as a client for the next like 20 or 30 years.
Well, yes, and so that's one bug in the system.
Hmm.
Now, it's interesting that you mentioned the retirement industry because so there was a reason why the federal government started enforcing a law that's known as ERISA.
Okay.
It was ERISA started in 1974, and basically it says that it basically says that employers need to serve in are fiduciaries of their plans.
Hmm.
Okay, you might be a fiduciary.
I got to buy
Um,
the ERISA bond every year. It's like
yes,
$250.
there you go.
Yep.
Perfect. So what happened in the retirement space 20 years ago, for people your audience that wasn't around then, was that the federal government started enforcing these fiduciary laws, and so it completely transformed the retirement industry. Where
Mm.
you used to have financial planners, financial advisors who basically got paid to sell products for a commission.
Yep.
They sold products. That's what they did.
Hmm.
And some products paid them much bigger commissions than others. So which
Right.
one do you think they're going to recommend?
All right.
Okay, great. So when the fiduciary law started being applied, they transformed from selling products for commissions to selling services for a fee.
Okay.
And so that was meant to align incentives so that, hey, instead of me selling you a product and being rewarded for selling your product, now I provide you with consulting services. Who are you? What are you trying to do? Let me understand your risk tolerance. Who are you? Right? You
Hmm.
sound like you have a pretty high risk tolerance. You want to swing for the fences.
Hmm.
Um, and so let me set you up with and procure the right, you know, financial vehicles to support your objectives. Let me procure those financial vehicles to help you meet your objectives. So those are all services. and so
Yep.
you should be paying your advisor a fee for those.
But that's not really how it works now. At least it doesn't feel like it to me. Like,
Well, I don't know if you're working with a registered investment advisor.
mhm.
Okay, well, they're supposed to, they're supposed to be serving you in a fiduciary capacity, small f.
Right, but they make 1% of the total of our uh fund or whatever it is. I don't even
Yep.
know if it's 1%. It might be 0.8 or something like that. So really their whole goal is just like get more money in the fund. Like whether we have a good year or bad year, like we still basically pay them that. Um
Yeah. Well, at least they make more money when your portfolio is worth more money.
yep. Yep.
Whereas in the brokerage industry, on the health and welfare side of the house, they make more money when your costs go up, when you get less
Mm,
value.
yeah. Right.
So it's like completely the opposite incentive to what you want.
Mm,
And so just to give you a quick story, there's a fellow here in Orlando by the name of Harris Rosen, who unfortunately died last year. But he was an incredible entrepreneur. Started his company Rosen Hotels in 1974. In 1991, he had an epiphany. He had about 200 employees at the time, and he said this whole health insurance thing is BS. Fired his health insurer, fired his broker, and said, "I'm going to figure this out on my own."
okay.
Okay, I mean, he was very, very ballsy. Um, and so he just started hiring physicians and nurses to be at his hotel.
I've had this same idea before. I was like looking at it, I was like, we could just like basically hire a doctor to be at our office like 24/7. Like I had that exact same idea. I was a smaller company, but I like the numbers made sense.
Yeah, yeah. So he was really a pioneer in finding alternative ways to finance and procure healthcare for his employees.
Mhm.
And over the next 30 years, he saved his company over $500 million. They now have 6,000 employees.
Wow.
And while I was working with Chubb, when brokers were my customers, I would sell my disability products to through brokers to employers,
Yep.
and that was all good and fine. But I was getting pretty bored of it. It's like disability is important, but there's not really a problem in that market.
Yeah.
Um, but this health insurance thing, I'd be at these open enrollment meetings, and like, man, people are pissed off about this health insurance thing, and
Mhm.
it's actually affecting my income too because now they don't have money, they can't afford to buy my stuff.
Mhm.
That's not right.
Yeah.
So I was like, why aren't these brokers adopting and recommending the strategies and solutions that Harris Rosen pioneered 30 years ago? You don't even have to reinvent the wheel. He already like laid it out for you. So
Mm.
um, I I said I was so naive. This is what I thought I was in. I said, if I just jump over to the brokerage side of the business, I can start scaling those kinds of innovative solutions. I can probably help a lot of people. I can probably make some money doing it.
Mhm.
And so I went and worked for a national brokerage firm, built a book of business, and within a year, I got fired.
Mm.
And it turns out that, um, because I was moving and recommending that some of our customers move to these more innovative solutions that Harris Rosen had pioneered in our own backyard 30
Mhm.
years ago, um, it required moving away from a particular health insurer. And I was told during my termination that, this health insurer pays us our largest bonus each year.
Mm.
And what you're doing puts that at risk. We don't like that.
Mm. So,
And so that's when I had the epiphany. I said, this is insane. Let's develop a management consulting firm that specializes in this area, but let's change the revenue model so that we don't have these misaligned incentives. And so we developed, what's one of the first fee-based management consulting firms that specializes in healthcare financing and procurement for employers.
mm.
And now there's an army of us that are growing out here doing these types of things to solve these problems for businesses.
So what kind of products were you selling to people outside of the norm when you were at Chubb? And is it very similar now to what you're doing? And like what? Because clearly you ruffled some feathers if you had built a book of business and were ostensibly bringing some amount of money in, but they just didn't like the way that you were going about it.
Yes. So you're wondering. I think the root of your question is, okay, what are these alternative solutions that are outside of Aetna and Cigna and United Healthcare and Blue Cross, right?
Correct. Yeah.
Yeah. So when you get into partially self-funded environment. What people know the term level funded these days a lot. Like,
Maybe just talk about self-funding and level funding a little bit.
sure. So the way that we look at this, the framework that we use is that we look at this as a maturity model. So as your organization grows and becomes more sophisticated, you should be becoming more sophisticated in how you finance and procure and manage healthcare for your employees as well.
Mm-hmm.
Okay, so yeah, when you're a startup, you just buy the commodities, off the shelf products, and you don't have no visibility, you don't know what's going on, and you just eat it every year. That's what you
Yep.
do,
Yep.
and that's all good and fine. But we meet with businesses every week that have been around for 50 years, and they're still doing that.
Yep.
And they wonder why they get 10% renewals every year.
Mm-hmm.
So basically, as you move through the maturity model, you increase value for your organization, right? You're the value, you're maximizing the return on your investment. You're getting more value for your employees for less money.
Should
Okay.
be. Yep. Got it.
Yeah, exactly. So instead of, when I talk about $300 billion a year in waste, that equals roughly $4,000 per employee per year in waste.
Mm. Yeah, I believe that.
That's,
I could see that.
yeah, that's how much the average employer overpays for healthcare each year.
Mm-hmm.
And so when you move through the maturity model, you start chipping away at that more and more. Okay.
Okay.
Okay, so let me answer your question. So, how do you actually do this? So, at a very high level, the first step is to stop paying for the things your population doesn't actually consume.
Okay.
Okay, so right now in the fully insured environment where a lot of small businesses are, and some of them should be there, you end up paying for a lot of services that never actually get used. And whether you have lots of claims or no claims at all, you pay the same amount. And so you would never do that in any other part of your business, right? Like if you had a bunch of seats for Microsoft licenses that weren't being used, you would get rid of them.
Mm-hmm.
Okay, so the first step is to just don't pay for things that you don't use.
Okay.
Okay?
What are examples of that?
Yeah, so when you're in that fully insured environment, if you have, let's say, an average claims year, average utilization, right? Average number of pregnancies, labs, imaging, surgeries, drug utilization. The carriers are making a profit on what's left over in your claims bucket each year. Like you fund this claims bucket every month,
Yep.
and 10% of what you're funding never gets used.
Yep. Makes sense. That's how insurance is supposed to work to be profitable.
Right. So get rid of that. And then after you've done that, the second phase of optimizing your supply chain is to stop overpaying for the things your employees do use.
Okay.
So I'll just give you a perfect example. Here in Central Florida, healthcare prices vary by over 1,100%.
Jeez.
You don't see that in any other market. Right?
Yes. Well, because the customer does not have visibility into what the price of the product is.
Bingo.
I mean,
You're 100% right.
that's something that I say over and over again. It's like, look, if this person's a better doctor than this person, I'm fine with one person charging more.
Yep.
Like, and I was just having this argument with somebody, and I was like, look, there's some surgeons I shouldn't be wealthy enough to afford. Like, there's some surgeons that should only operate on like NBA players.
Yep.
Someone was like, well, what if you wanted to use them? I was like, I can't afford them. I can't afford like a Bugatti. Like, I don't
Right.
get that. It's not my right to have access to that surgeon. I got to move down the surgery chain. Like, that's the way that I view it. Maybe some people might think that's a crazy idea, but yeah,
Well, what you're describing, of course, is a functioning market.
a market. Yeah. And
Right.
like to be a good surgeon that demands a good price, like you have to provide good service, good quality, good follow up. You can't be an asshole to your patients. Not to
Yep.
mention, just like there's just no visibility into doctors and how good they are at their job. Like my girlfriend works in surgery and she's like, some of these doctors are horrible. And I'm like, how would I know that? Like,
Yeah.
nobody ever says that like out loud. It's like this weird taboo in the medical industry. Like we protect our own. That like
Mhm.
no one will say like, hey, I would not go to that surgeon. Like I've seen that surgeon do some bad surgeries. And I'm like, I'm hearing these stories and I'm like, well, how would I ever know that? Like that's a bad surgeon. Don't go to that surgeon. And then, I walked into this. I was talking with one of her friends. We ate dinner with one of her surgeon friends, and she's like, "Oh, I'm a part of a surgery group. We're all like OBGYNs." And I'm like, "Oh,
Yeah.
that's cool. So like how do you decide like what patient goes to what surgeon?" And she's like, "Well, it's just whoever has availability on their calendar." And I was like, "What?" I was like, "So you have 12 surgeons and 1,000 people come in and they just get assigned to you pretty much randomly." She's like, "Yeah, pretty much." That like blew my mind. I was like, "How is that possible?" Like that
Yeah.
there's not like "Oh, well, this surgeon's a little bit better at this thing. Like they kind of do these like 6 types of cases are those." And then it's like, "Hey, yeah, that's the highest price surgeon. Like they're the oldest, the most senior, they're the best. Like if you want to go to the best, go to this person. But if you're like, okay, in the middle, go to these people." I was just blown away that they were like, whoever has time on their calendar takes that case. I was like, what?
Yeah.
How is that our best sorting method?
It's unbelievable, and I think it just really speaks to the architecture of the system that it doesn't reward those kinds of efficiencies or value.
Yeah.
Like
That's
it's just not built that way to even do something you would think is so essential in the purchasing and uh, decision. Like who are you going to see?
just whoever
Yeah,
they pair me up with. I was like, what? I'm like, what if they don't ever like what if they don't know anything about my specific case? And it's like, well, they're all like general, like, experts. And I'm like, I hate this. I just totally
yeah.
hate this.
Okay,
Um,
here's an interesting local example that's it might blow some of your listeners' minds, but let's say you've got an employee in the Tallahassee region of Florida,
okay.
and they need a new knee. They need a total knee replacement.
Mm-hmm. Is
And let's say their specialist that they go to works for Capital Regional Hospital in Tallahassee.
that a big one?
Yes, and
Okay.
and, and of course, because the specialist is owned by and works for the hospital, they're going to recommend that you go to that hospital and have your surgery done there. Of course, that's why the hospital bought the employs the surgeons or I'm sorry, the specialists and the primary care physicians,
Could
right?
we
That's why
could
they're
we just
buying
stay
them.
on that surgery center thing for a second? Because I know that this is like another crazy rabbit hole that you can go down, like where the surgeons can own the surgery center or they'll own a portion of the surgery center and get like kickbacks. It's just
Yeah,
so gross, the whole thing.
it is. So if your employee lives there and okay, they're scheduled to go get the surgery done at Capital Regional, it's going to cost your plan. Meaning, here's one of the takeaways I always like to emphasize with employers is that companies pay for nothing. They take on no risk. Insurance companies take on no risk. You, the employer, and your employees are the ones paying for all this stuff.
Okay. Well,
Full stop. Full stop.
now you're gonna have to explain that to me, right? Because I thought, my company pays in, whatever, $500 a person times, let's easy simple math, 10 people, so that's 5 grand times 12. So we've got our bucket of money that we're paying into the insurance company every year. Can't my
Yep.
claims exceed that? And then like if something, my broker says like, well, what if someone has like a preemie baby and they need to be in the hospital for a month? Like, can't my claims exceed that bill and then the insurance company loses money that year?
Yeah, but they buy reinsurance. They transfer the risk. They take a small portion of your premiums and they buy reinsurance for
Mm.
that NICU claim.
So then, wouldn't eventually some insurance company have to lose money?
Yeah, but it doesn't. I mean, it doesn't really happen. Not in the health insurance space.
Well, I mean, I can just Google right now, like, what's the net profit of health insurance companies?
And it's actually okay. So, but you can't just look at the health insurer because the health insurance is almost a loss leader. So
Okay.
since you love policy, let's go back to the Affordable Care Act
Yep.
and some of the unintended consequences of the Affordable Care Act. Um, the ACA did some wonderful things, no question. But one of the really pernicious things that it did was instill what's called a medical loss ratio rule. And you may be familiar with this,
No,
but
no.
basically what it says is that the argument was, listen, you health insurers, you guys are making too much money. Here's what we're going to do. We're going to cap your profit margins on fully insured group business. So if you you have to pay out 80%, 80 cents on every premium dollar has to go towards claims.
Okay.
Eight
It's one of those things that sounds good in theory.
sounds great in theory,
Mm-hmm.
and
And is that the idea there that they'll stop denying claims because they go, hey, look, we can't make 50% profit margin. Like we have to, make, our best is 20% margin. So let's pay out on these claims that maybe in previous we would have denied. Or you want an MRI for your abdomen that's in pain, but like you don't really have a medical case or a logic for that. So don't pay that.
yes, you're exactly right. It was positioned as a consumer protection,
Okay.
right? So the health insurers, they said, oh, you're gonna cap our margins. Here's what we're gonna do. We're going to vertically integrate. We're going to buy the supply side. We're going to make money off of. We're going to buy pharmacy benefit managers.
Uh,
United Healthcare is the biggest owner of physicians in the country.
So they said, okay, well, we can't deny the claim for the MRI any longer. So let's just go buy the MRI facility. So then I can just pay. Yeah, sure, I'll approve it, but I'm just moving money from one of my businesses to the next.
Yes, yes.
Interesting.
I mean, I think United Health Group owns like 2,500 businesses, all in the healthcare
Mm,
space, mostly on the supply side.
mm, interesting. Okay, I did not know that.
And here's the last nail in the coffin is that the organizations that sell all these supplies, medical supplies to hospitals, are known as GPOs, group purchasing organizations.
Okay.
Several health insurers have formed their own GPOs where now they're selling all the supplies to the hospitals,
So like, gauze and like,
instruments.
inserts, screws, things like that go in surgery and joints and
Yeah.
orthotics and stuff.
Yeah. And so talk about the unintended consequences. Now these screws that are just screws
Mm-hmm.
cost, $75 each.
Yeah.
And my uncle's been a nurse anesthetist down in South Florida for 30 years. And he's like, the things that we used to sterilize, the instruments that we used to sterilize and use over and over and over again and never go bad. Now, since these new GPOs are owned by health insurers, we use them one time and we
Yeah.
throw them out.
Yep.
And they're thousands of dollars of equipment
Mhm.
every time. And so this, in a sense, health insurance has become a loss leader for selling hospital services. And if you look at the earnings reports of some of these insurers, selling drugs, half of their earnings are coming from selling drugs to employee populations.
Mm. Okay, so let's just talk about then, like, where are the big costs coming from? Like, I'm sure there's a bunch of things that go into the costs, but what I hear on the news is that we have mediocre health outcomes, but we pay by far and away more than any other country pays for health insurance. Like,
Yeah,
where are all those costs like coming from, essentially?
great question. So if you look at the average population and their claims, um, about 50% of, so just mind you, like in any population, it's about 5% of the population drives 50 to 70% of the total spending.
5% drive Pareto distribution.
Yes.
Unfortunately, the unhealthy people, or the elderly, or women who have 7 kids, I'm not saying that's bad. I'm just saying that they're going to drive the cost of healthcare.
Yes, yes. And sometimes you just don't know who it's going to be, right? I mean, we have a saying that there are no good groups, there are no healthy groups. They're all going to have bad years.
I
It's
see.
just the way it is. And that's okay. But yeah, so about 50% of claims come from hospital services.
Okay.
Okay, so yeah, it could be that NICU claim, premature baby.
Yep.
Um, what used to be about 10% of total claims was prescription drugs, and that was about 10 years ago.
Wow.
Now we're at the average group is running about 30% of
Okay.
total spend is on prescription drugs.
Okay.
So it's the fastest growing financial risk within a health plan is your drug spend. And it's because of this vertical integration where, again, what does a PBM do? A pharmacy benefit manager. A pharmacy benefit manager was intended originally to help employers optimize their drug supply chain, help us purchase drugs cheaper.
Mm,
And then what happens within 10 years of that financial service being offered, or administrative service being offered? Drug manufacturers bought the PBMs.
mm.
They captured them.
So, can you explain like how the drug manufacturer, the pharmacy benefit manager, then the pharmacy, then the doctor, and then the actual patient? Like, can you just explain maybe that like relationship there? I guess the insurer too is intertwined.
Yes, because the insurers have all bought. So since we have these medical loss ratio rules, where it basically rewards, um, it's almost like a DoD contract, where yes, exactly, it's a
It,
cost plus
it
contract.
rewards high costs essentially. Like, it
Yes,
doesn't really benefit you if your costs go like 120%, but like you have to get to 80, so might as well get to 80.
yeah, exactly.
Mm,
Um, so So yes, to answer your question, all right. So what's the relationship between what's the drug supply chain look like?
yeah.
Um, the
And
intent of a pharmacy benefit manager is to help employers manage their drug supply chain. And right now, you've got what are called the big three PBMs, are all owned by health insurers. They control about 80% of the market.
mm,
Okay, and what's really fascinating is that these employers that expect brokers to help them also manage their supply chains, the PBMs are actually paying the brokers in many cases. So for every time one of your employees fills a prescription drug, your broker might be getting paid $1 to $5 per script.
mm, interesting.
Yeah. So if you look at the earnings reports of these publicly traded brokerage firms in their 10K earnings reports, they talk about it. They have a great euphemism for this revenue stream. They call it market derived income, MDI.
Market derived income. It's a kickback
It's
essentially.
a kickback. Yes,
So
yes,
then how is the broker going to be affected? The broker then is going to do what? Recommend a certain health insurance company, like let's say Blue Cross, and then Blue Cross owns the pharmacy benefit manager. And
yes.
then
So yep.
when I go to get my prescription for Ozempic, then it will pay back to the broker, like reward them for essentially picking us as the insurer.
Yeah. So like what you're describing is kind of like the early stage where you're buying one commoditized health insurance product that has the PBM embedded in it.
Got it.
When you start talking about self-funded employers, and mind you, 60% of employees in the country are actually on self-funded plans. Um, you can start carving out and selecting your own vendor stack, so you can pick out the pharmacy benefit manager that you want.
Mm,
So you think about it, the employer is expecting the broker to recommend the best pharmacy benefit manager for them. The broker recommends the pharmacy benefit manager that pays them the market derived income. And
mm,
we wonder why 80% of the market is using a big three PBM whose financial incentives are diametrically opposed to the employers. So these big
interesting.
three PBMs, their revenue model, here's their offer to employers. Look, hey, our service is free. We just mark up the price of the drugs to cover our administrative costs. You'll never know how much that is. You'll never know.
Hmm.
But hey, we're owned by Cigna or whoever, and this is what everybody does.
Hmm. So is there really a role anymore for the pharmacy benefit manager? Like, is that in any way, shape, or form beneficial?
Well, it depends on their scope of service, and it depends on their contractual relationship with the employer. So there's a new breed of, and they're really not that new, but newer breed of what are known as transparent PBMs or fiduciary based PBMs,
Hmm.
who some of them will actually embrace a fiduciary relationship with the employer via their contract. And that's critically important
Hmm.
because it says, hey, I contractually have to do my best to help you achieve your objectives. That's my job. So that's a legal construct, and it's really important. So yes, there's a couple things. Those PBMs they will help manage your healthcare supply chain, help drive down the unit price that you're paying for those drugs, and so that's really important,
Mm-hmm.
huge. The other thing they do is provide clinical oversight, and they work. And again, if you select the right ones, they work for you, and so they're trying to help you optimize your drug spend, right, for efficiencies, and so you're not getting ripped off, right? We've got examples where if you've got a drug that's prescribed in a 10 milligram dosage, it might cost $700 a month. But if you got it dispensed in 5 milligram pills, it might cost $35 a
Mm.
month. Like there's all kinds of games that are played in this space. You may be familiar with some of the recent litigation against Johnson and Johnson.
I'm not sure I am.
Oh, this is juicy, and I mean, just layers of irony here. So basically, the story is the allegations are that an employee was taking a drug that cost about $10,000 a month total, all in, and sure, their copay might have been $200 or whatever it was,
Right.
but the total cost of the drug to the plan, the employer, was $10,000 a month.
It's a lot.
It's a lot of money, and this is very common for these specialty drugs.
The way I heard a broker say it is any of the drugs that you see like advertised at football games, he's like, those are gonna be like crazy high priced.
Oh, 100%.
Yeah.
100%. And one day the employee went to their pharmacist and said, hey, listen, like, how much would this drug cost if I just paid cash for it outside of my company's plan?
Yep.
How much would that cost? The answer? Well, not $10,000, but $78.
Whoa.
So the employee
It was actually lower than their
Right.
deductible.
Yeah.
Crazy.
Lower than their copay.
Yeah, right. Or yeah, their copay deductible, yeah.
And so the employee sued the fiduciaries of Johnson and Johnson, the CFO, the HR person, sued the broker, sued the pharmacy benefit manager. Said, "What are you guys doing?"
Yeah, reasonable. To me, it seems reasonable.
Yeah. So I'm glad we're talking about all these things because there is an army of people on the supply side of the equation working diligently every day to figure out how to extract as much money as they possibly can out of employers and patients.
Mm.
That's their job. In fact, there's a whole industry for it. It's called revenue cycle management, RCM. And they hire the biggest consultants in the world. They spend millions and millions of dollars with McKinsey and Company, with Deloitte, etc., to help them figure out how to do that.
So what was Johnson and Johnson's justification for this $10,000? Like, how did that get to $10,000? I guess is my question. Like, what were the things that happened in between then to get to 10 grand?
Yeah, so we talked about how the legacy revenue model of the big three PBM is spread pricing. They're gonna buy the drug for one price and then mark it up for an amount that you will never know. You'll just know the total cost. You won't see how much they marked it up for.
Right.
And so that's really at the root of why there's such a price increase, because they simply can. And no one's watching the store. No one's managing this healthcare supply chain. The broker's not going to do it. They're getting the market derived income from the PBM.
Yeah, geez, they might be making $1,000 off of every single time that prescription's filled. I mean, that's amazing. That's a great revenue,
Exactly. So you've got the fox guarding the hen house. And so my first, when we look at the broad steps of a healthcare transformation for this country through the employer channel, which again serves 164 million Americans, the first step is getting unbiased advice. Because if you're not getting unbiased advice, you'll never get to the strategies and solutions to actually solve these problems. We won't see them.
Okay, so how are most of the other people in the United States that are not covered through an employer being covered? Is that through Medicare, Medicaid, that kind of thing?
Yeah. About 40% of Americans are through Medicare and Medicaid, and then the last 10%, give or take, is on the ACA individual exchange.
Okay, so what about those? Because that's also a big portion of the American population. Like, Are
Yeah,
there?
it's, I think it's roughly about 20 million Americans yeah, maybe even more, maybe 25 are on the ACA exchange right now, which by the way is forecasted to have the biggest price increases they've had since the inception of the marketplace in 2014.
Mm,
This
so
year coming up.
so I know, because we keep track of where the money through the government is going. I know an enormous amount of government expenses is Medicare and Medicaid. Of course, Social Security too, which,
Mhm.
not the topic of today's discussion. But
Mhm.
what about that? Like, are there problems associated with Medicare and Medicaid also? Is that a better solution? Maybe talk me through that.
Yeah, I mean, I like to say, well, if you want Medicare for all, that what that really means is Medicare for no one.
What do you mean
Because
by
you're
that?
really doubling down on a program that's unsustainable.
Yeah, right. Because the costs. I mean, we're already what, $2 trillion over budget every single year, and
Yeah.
just literally this morning, I was listening to Ray Dalio, and he goes, "Well, there's certain things that you just can't get rid of because they're already, what do you call them? We've agreed to pay these out." Um, and I went,
Yes.
"Well, do we have to pay them if we can't pay them?" It's like, "I have to pay my mortgage." Well, I don't have any money. It's like, you have to pay. It's like, pay it with what? Like, what are you saying?
Yeah.
So yeah.
Yeah. Yeah. So the whole Medicare space is, and I feel bad for clinicians, because the government's kind of a bully. I mean, the government says, "Listen, here's what we're going to pay you, and if you want 40% of the marketplace that does 75% of the spending, $3 trillion a year, you have to agree to our terms."
Yeah, and I've heard that
And so it's really
sometimes
not a market.
that's not
Yeah.
super.
So go ahead.
No, I just heard it's maybe just not always super profitable to take those gigs, but I don't know. Again, you never have that cost in the back end.
Yeah, so I mean, the argument for so Medicaid, right, actually the payments are even less. So
Mm,
on Medicaid, um, hospitals always say that they lose money on Medicaid patients, and that's why they have to charge employers three times more.
mm,
That's always been the argument. So here in Orlando, we've got two major health systems here. One charges 3.6 times more than Medicare patients,
okay.
and the other one charges employers 2.8 times what they charge Medicare patients, but also has better outcomes than the more expensive one. Um, so, so there are watchdog agencies and think tanks and things like the Rand Corporation. The Rand Corporation does these studies, are fantastic studies, where they basically forecast, okay, based on all these different market conditions, here's what we think the cost basis for this hospital is in this region for these services.
Okay.
Okay, here's what we think the cost basis is, and so in some cases Medicare is coming in below their cost basis. In some cases, in lots of cases, the projections are that Medicare and Medicaid actually pay above.
Okay.
So there's enough margin there.
Yep.
Um, but yeah, it's a that, and this is one of the challenging things about talking about healthcare in general is that it's like there are the Medicare space is completely different from the employer space.
Mm,
The incentives are different, the payment structures are different,
mm,
and so it's like you can't make these broad universal statements because they're completely different industries, and you have to have multiple administrative layers to be able to play. If you're going to play in the employer, the commercial market, and the Medicare market, you have to have different infrastructure in place to accommodate those customers.
mm,
Um, so yeah, it's a real challenge. I'm not an expert on Medicare and Medicaid. It's really the employer space is where I live. But yeah, I agree. It has to be addressed. It's going to be addressed, whether through orderly reform or disorderly chaos and people getting upset.
mm. Yeah, CEOs getting gunned down in the street, right? I mean, that's kind of just an example of how crazy it's gotten. When that happened, people were like, "Yeah, well, you know, we get it. Like, we kind of understand where that kid was coming from." Um, but so as far as like Medicare, Medicaid goes, you said that the hospitals claim that they're losing money on it. You said maybe they are, maybe they aren't. But is it reasonable to say, like, even if they're breaking even, then to your point, then the employers are covering all the excess profit that they would have essentially made or lost or broke even on or had small margins on.
Yeah, our huge, our nonprofit hospital here in town is the biggest landowner that pays no taxes,
Right.
and they charge employers 3.6 times what they charge Medicare
Mm.
for the same services done by the same people at the same place.
And they unabashedly just say that, like, we have to charge all of you to make profit. Like, you are our profit center. Um,
Yes,
that,
yes,
that's
for the
It's so crazy. Think about, like, yeah, like, if again we go back to our car distributor, it's like, someone walks in and it's like, how much is that Honda? It's like, that's $4,200. You're like, oh, that's a good price. Be like, oh no, yours is $14,000. It's like, wait, why? And it's like, well, because I make no money on that, so I need to make all my money off of you, buddy. It's like, like, no, like, there's some
yeah.
choice words I could have for you. Okay, that's really interesting. So, if the government got involved at a higher level, um, what could they even do? Because here's my stance. I think you probably agree with me. Um, People go, "Oh, that's the company's fault," and I say, well, partially, but I tend to think that if the government hadn't gotten involved and gummed up the works so many times over, that these
Mm.
companies wouldn't have these weird loopholes and rules and regulations. Like, the bottled water market is not inefficient to the point that I can't go to a gas station and buy a bottled water for like $1. It's like, it's because that industry hasn't been so highly regulated and messed around with that it's become so chaotic that it's impossible to do the right things. Tell me if I'm right
Yeah.
or wrong with that idea, or if you.
Oh, I think you're spot on. I mean, one of the reasons why United Healthcare's stock is tanking right now is that they're under investigation from the DOJ.
Yeah.
I mean, so basically, you've got other parts of the government that are trying to rectify some of the policy-driven misaligned incentives
Mm-hmm.
that are self-inflicted,
Mm.
right, by the government.
Yeah.
So yeah, so just to give you a couple, and so I've been on our National Trade Association's legislative committee for a number of years, and I don't speak for them. But one of the things I advocate for are a couple policy suggestions
Okay.
that I advocate for. One is to get rid of the medical loss ratio rules that we discussed. They're the reason why these health insurers are incentivized to vertically integrate
Mm-hmm.
and buy up the supply chain, which they're supposed, employers think that they are helping them negotiate with. That's not what they do.
Mm.
The second big thing, and this is not sexy at all, but it's hugely important. One of the things that was implemented in the ACA was something called the no lifetime maximum rule.
Okay.
And what that means is that a qualified health plan, which if you're a large, what's defined as a large employer in the United States, you have to offer a qualified health plan.
Okay.
Okay, by law, which of course that's a crazy. I have to purchase this for my employees. Why? Anyway, that's a whole other conversation. But what the no lifetime rules, no maximum lifetime rules mean is that your health plan, which again you pay for that, you the employer and your employees pay for all this stuff. There can be no cap on benefits. None.
Okay.
So just to give you an example, so this creates, and again, let's talk about irony. The insurance industry created this term called moral hazard years ago.
Yeah.
Because they understood, and of course, Dr. Paul, speaks about this very eloquently, that if you give someone too much of a safety net, what do? They take on more risk.
Mm-hmm.
And so it used to be the case that, like, okay, your health plan would cover up to $2 million a year in care,
Okay.
which that's a huge amount of money.
Yeah,
I mean,
that's
huge.
like a month in the hospital, or maybe longer, right?
Longer, yeah. I mean, that's an insane amount of money. So since that rule was implemented in 2014, where there's no cap on what your insurance company or you, the employer, at the end of the day, has to pay and cover, the percent of incidents of claims exceeding $1 million has increased 322%
Mm,
since 2014.
mm,
And it's because, listen, your employees, Alexander, they're showing up to the doctor's office with an Amex card, and they slap it down on the desk and say, "Charge me whatever you want."
hmm.
I mean, there's no limit. I've got all the money in the world.
Right, because
There's no limit.
the hospital will essentially never see any downside from just billing you for anything and everything. It's like you said, yeah, it's like, hey, the credit card has no limits, just like go frolic and shop, buy whatever you want. The only person that sees any of those costs would be first, potentially the patient, but they're going to max out at their deductibles. So then all the, funds get rolled over to the next year renewal for the company that's like going back for an insurance plan.
Yep.
And then like
Yeah,
the,
and you think about it from an actuarial perspective, like, okay, again, 60% of Americans employees are on self-funded plans, and in most of these self-funded plans, they buy reinsurance to protect from catastrophic loss. That's real insurance.
yeah.
That's what real insurance is, right? It meets the definition. Um, how, as an actuary, an underwriter, how do you budget for an unlimited liability?
Right. Yeah.
What?
Yeah.
I have to be super conservative because I just don't know.
Hmm.
I'm on the hook for everything?
Well, again, what I was going to say is like the person who walks into that hospital with the unlimited credit card, they never see any downside. So they never even have any like negative feelings towards the hospital because they probably won't even see what the hospital billed for. So it's like one thing if like you walk into the, luxury store and then you walk out, then you look at your bill and your eyes get, wide, like, oh my God, I bought a $700 shirt. But like then you'll be like, "Oh, I'm never shopping with them again. They overcharged me." But like people don't even see that. So then they don't even think XYZ hospitals like a crooked organization because they don't even really see the costs that they billed them. And also they don't know the costs of like what should have been used in that surgery. I mean, my girlfriend tells me all the time too, like we'll just open up everything in the surgery and just throw half of it away. And then you get billed
Yep.
for it. Like you didn't have to get billed for that.
Yep. Yep. Absolutely. So it's amazing that this is the state of this industry that created the term moral hazard.
Mm,
Because now we're all about moral hazard. I mean,
yeah.
it's everywhere. It's permeated the whole system. And I would say the whole country. If I mean, we could of course go down the monetary policy rabbit hole,
Mhm,
um, but they're intertwined to some degree.
mhm,
Um, so anyway, it's a very challenging space, but a prerequisite for solving these problems and reclaiming that $4,000 per employee per year in wasted profit is to get unbiased advice.
mm,
If you're not getting unbiased advice, one, you're not fulfilling your fiduciary responsibilities under federal law. You're relying on conflicted vendors, which is a prohibited transaction. But more importantly, you're just wasting money and you're hurting you're undermining the financial and physical health of your organization. So get unbiased advice. Go to the Validation Institute's website. There's a list of fee-based management consulting firms that specialize in this area, that sit on your side of the table contractually, and they will give you unbiased advice. That's what they do.
mm. So, are there other, like, policies that are out there that you think are really harmful to US consumers? I mean, I know you named 2, but are there additional ones that's like, "Hey, we could just get rid of this, and this would help
Oh,
a lot?"
yeah. So you'll love this. One is known as and the acronym's fantastic. They're known as con laws.
Mm.
You may be familiar, but
No.
con stands for Certificate of Need.
Okay.
And so basically, some states have much stricter con laws than others. Like, so for example, I'm from upstate New York. New York really had a major problem throughout COVID because they had a big shortage of healthcare services,
Mhm.
right? Hospital beds. But of course, New York also has the worst con laws in the country.
Okay.
So what this means, like basically, this is a rule. Talk about uh, industry capturing the government, right? Capturing regulators. Um, Hospitals basically said, legacy hospitals go to regulators and say, listen, we need to really limit the supply of hospitals in hospital beds because we don't want these people to build these hospitals and they fail because there's just not enough demand.
Right.
So what we're going to have the governments um, create these mandate that new hospitals have to get a certificate of need
It's kind of
from the government.
like a liquor license to open a bar.
Yes,
Yeah.
yes. And I actually used to sit on a board for what was called the Health Council of East Central Florida, where the reason that this Health Council was originally created in 1981 was to analyze the certificate of need requests
Mm.
for people that want to build skilled nursing facilities, et cetera,
Okay.
here in Florida. Now, luckily, Florida's gotten rid of most of their con laws, so I left the board because there was no reason to be on it anymore.
Mm.
Um, but this is, I mean, this is at the state level that this exists. And so it's total cronyism. It distorts marketplaces,
Mm-hmm.
and it leads to inefficiencies, right? I mean, you've got, okay, we're limiting the supply of something, so of course prices are going to go up
Yeah.
because you limited the supply artificially.
Yeah, I can't really make any logical case for why not just have a private individual build a hospital. If it fails, it fails. Like, what's the downside of having too many hospitals? Like, who's ever been like, gosh, these hospitals are just so unsightly, they're dotting our corners. It's like, if it works, great. If not, like, there's no limitation to the amount of restaurants that we can put, in your
Right.
city.
Yeah. Yeah, it's just craziness. And and speaking of building hospitals, I don't know if you've got any buddies in the construction industry, but if you talk to general contractors in the commercial space, they'll tell you their best customers are hospitals,
Mm.
high margin and high volume.
Mm. I don't have anyone in that, but I have a friend who's really tied into the sports business, and I'm like, where do a lot of these people make money? And he's like, nursing homes. He's like,
Mm,
these like people own these chains of nursing homes, and it's just like a cash cow. I'm like, God, that's so unfortunate,
yeah.
to just think about that. And then when people like can't pay, you can like start to go after their estate. I'm like, ugh, that's just so gross.
It really is. I mean, and so the net effect of this inflation amongst health plans, um, and how it's really undermining wage growth is that you look at. I mean, you've got employees that most of them don't have $1,000 in savings,
Hmm.
and then but they've got they're on a $5,000 HSA plan,
Right.
and so one trip to the ER and they're out of money and they're in debt.
Yeah.
One trip. And so the compounding issue for hospitals is that their collection rates are now horrible,
Oh yeah.
right? They're collecting like, I don't know, 60, 70 cents on the dollar.
Yeah. Well, I
Um,
got a hospital bill sitting right here in front of me. I went to a doctor, sat down with him, had a 15-minute conversation. He's like, "You're good, no problem. Like, have a good day. We'll see you soon." $314 bill, and
Yikes.
I'm like, where's like it's annoying because they gave me a form and I had to fill it out. And I wrote in my primary and my secondary insurer. And then I called in today and I was like, doesn't look like you billed insurance. She goes, oh, we don't have the insurance information here. And I was like, I wrote it on the form. I know I did because the form was like 6 pages long. And I was like super annoyed that I was filling it out. Again, that could be just a nothing, but it's like, why is this such an like stupid system? Like it's just
Oh yeah.
it has no resemblance of the free market at all whatsoever. You walk into
Yep.
these offices and they're ugly, and I'm like, why is this doctor's office so ugly? It's so drab. Like, how is this person making $300,000 a year? Like, why is the McDonald's that I walk into prettier than this?
100%. It's just remarkable. You probably had some of your employees have, or maybe you've had this happen where you get blood work done and Quest or LabCorp, they will not only bill your insurance, but they'll send you an invoice as well
I don't even
for the full amount.
yeah, I mean, I don't even go to like a primary care physician. I just pay out of pocket. I just pay
Yeah.
everything out of pocket now. Like I get my blood work done and it's quite expensive. It's like 500-600 bucks, but I'll do that twice a year and I almost never have to go to the doctor. This is the first time I have to go to the doctor in 2 or 3 years. I'm, like, wondering to myself, like, should I just not have medical insurance? Should I just get, like, an accident plan or something? But I know
Yeah,
people tell me
yeah.
that's crazy.
That's crazy talk. So what's really fascinating is like some of the people in my corner of the industry who are doing these types of things. Yeah, they tend to be they tend to they're solo consultants, or they have very small firms like mine, and quite a few of them are actually on. There's a couple health sharing organizations that are pretty good,
Mhm.
and I mean I've been my family's been on a health sharing organization for 5 years. We had our second baby while we were on it. It's been awesome.
What is a
I
health
mean,
sharing organization?
so a health sharing organization is something that's actually, ironically, not deemed an insurance product under the state, but actually functions more like actual insurance. It
Mhm.
doesn't pay. It won't cover anything that's maintenance related. It won't cover your statin or anything like that. But it covers catastrophic things. So any accident or illness that exceeds, for in my case, $1,500 worth of care, I pay the first $1,500, and then the plan pays everything else. So when we had Abby here, um, we paid $1,500. The plan picked up everything else, and it was just so easy.
Now,
And it saves us about $25,000 a year
do you
compared to buying a traditional
now
health insurance.
here's a question. Do you have to be able to, like, qualify for that? Because this is, like, the one conundrum that I always run into, like, well, what if I, am type 1 diabetic and my medical insurance is just obviously going to be more expensive than, healthy young Alex. Or even,
Mhm.
here's one for you, and I'm sure we could go into depth on this. Health insurance for women is more expensive. Well, that's not
Mhm.
fair. It's like, no, women have babies. Like the woman has to go into the hospital generally and have the baby. So, like, when I found that out, like, very early on in our company, we had a policy where it's like their cost, plus whatever the margin is. And I was like, well, why are the girls' health insurance like $400 a month and mine's like 200? My broker's like, well, women are just more expensive. And I'm like, well, why wouldn't I just not hire any women? And she was like, whoa. And I'm like, well, I didn't make this up. You made this up. Like this, like I was like, this is just like the financial incentives are not good here for
Yeah.
us. So yeah, like, do you have to qualify for that plan?
No, you don't have to qualify. However, so just to level set here, like people are always looking for like this silver bullet, like one product that's going to like fix everything for everyone,
Yeah.
and it doesn't exist. Like no product is good for everyone,
Yeah.
and something I think is garbage for me is great for someone else.
Hmm.
Right? It's what they want based on their risk tolerance, their needs, their stage in life, whatever. It's what they want, and that's fine. So um, one of the challenges with health sharing organizations is that they generally don't cover pre-existing conditions for the first couple of years,
Okay.
right? So if you've got a serious pre-existing condition, something that actually is going to cost a lot of money to to treat,
Mm.
health sharing is probably not the best fit for you. But if you're diabetic and you can manage your diabetes like you should because you want to be healthy, it's actually not. Diabetes can be managed for $8,000 a year. Whereas if you don't manage it and you end up in the hospital for a week, that's a $50,000, $70,000 claim, and
Yeah.
you lost a week of work.
Yeah. So is it just, you say that nothing's perfect. Um, is it just that some people in some conditions in some situations are gonna be more expensive? Like there's no way around that, right? Like
Yes.
if I'm a type 1 diabetic, I'm kind of just unfortunately born with something that's not going to be cost efficient or effective. And is it like we're kind of trying to not make that person have to bear that responsibility that's part of the issue with healthcare?
Yeah, I mean, we're really getting into the philosophical, part of answering the question of, what's my responsibility to you,
Mhm.
right? I mean, and so we could go 17 different ways to try to answer that question, and perhaps we should as a society,
Mhm.
because I think it is the ultimate question. What is my responsibility to you?
Yeah. I know that your kids are kind of demanding time from you here, but maybe just like kind of to round out, like if if you were going to redesign the system, and or maybe if there's a country out there who you go, yeah, that system's actually pretty good,
Mm.
what would that kind of look like, and what would be the fundamental changes that would have to happen from our health insurance system at the current moment?
Yeah, yeah. So it's fascinating. People. It's very tempting to say, well, why don't we just do it like the Netherlands,
Yeah.
or why don't we just do it like Singapore?
Yeah.
They're very small. They're the size of Manhattan.
Mhm.
It's a very different situation, right? And you think about our country of 330 million people. The people in Texas have different attitudes about things than the people in New York
Yeah.
and New York City, and that's okay. So I think trying to shove a one size fits all solution onto a population of 100 330 million people is just I think that's inherently challenging. Um, but let's talk about some bright spots though. Besides the a growing list of employers that have really helped to gain a strategic advantage in the war for talent and reducing costs while they're doing it. So we've got more a growing list of employers that are figuring these things out. But let's talk about the most successful one of the most successful health systems in the world is actually in Canada in Alaska.
Oh.
It's the Nuka health system, and they're so successful that even the folks from Singapore came over to learn and adopt what they can from the Nuka system.
Mm.
And so, Singapore has one of the best health systems in the world, and the philosophy around how they're delivering care is very much informed by what they learned in Alaska.
So what
Having
what are they doing differently, from the remainder of the U.S. healthcare system? Because I wouldn't have thought any state was really winning this thing.
Yeah, yeah. So I mean, it's really cultural. It's like the fact, like, and I was fortunate enough to have a dinner with Dr. Ebby, who leads the Nuka group up in Alaska a couple years ago. But he was really talking about the culture of their health system. They don't call people patients,
Mm.
right? It's just a very different attitude. Um, and talking about the teamwork and the integration of how they care for their people. And we're talking about a population that frankly has lots of chronic diseases.
Yeah.
Like their population has a lot of challenges, and so but they're delivering high quality care at a very low cost and producing outcomes for them. Despite some of these socioeconomic factors that are not, helping them on the scale there.
Mm.
Um, so that's that's kind of like an outlier. But what can we do as a society? So one of the ideas, like there's a great book by David Goldhill called Catastrophic Care. It came out in 2013.
Mhm.
David Goldhill is the CEO of Sesame in New York City,
Okay.
and I always recommend that book. In addition to my own, of course, which is coming out later this year. But that book is just phenomenal. And one of the things that he recommends that we could potentially do as a solution in this country is, and you probably disagree with this recommendation, but is to have a fund for catastrophic end of life care.
Okay.
So, and the reason he makes that argument is that back when that book was written in 2013, the average senior um, throughout their life, they put $100,000 into Medicare, but they're receiving $300,000 worth of care.
Yeah.
And most of that is right at the end of their life.
Yep.
You've got people in their 90s having major surgeries. I mean, so it's just, so that's one idea. And he goes into a lot more depth than that. But as far as like just basic blocking and tackling, get unbiased advice so you can actually start managing your supply chain, so you can actually see pricing information, because you can see pricing information if you actually know how.
Yeah.
Okay, as an employer, and then you can start optimizing for value so that your employee in Tallahassee who needs that knee replacement, he doesn't go to Capital Regional and have it done for $100,000 and have a poor outcome because they don't do it, very many of them. He goes to Mayo Clinic over in Jacksonville, an hour away, has it done for $30,000 and has a much better outcome because they do 500 of them a year there.
Mm-hmm.
Like, I mean, you think about that. That's a $70,000 savings, and they had a better outcome.
Mm-hmm.
But you have to know these things to be able to take advantage of them.
Yeah, I feel like for me, the most obvious thing would be like just stating your price somewhere that the customer could see it. Like, is
Yeah.
that like, am I oversimplifying it? I feel like that would solve like half of this.
Oh, yeah. I mean, in fact, I'm not sure if you're familiar with the Free Market Medical Association,
Mm-mm.
but yeah, check them out. And one of the guys who's very, big in that organization is God, Keith. What's his last name? Last name escapes me. But anyway, he's a surgeon. He opened what's called the Oklahoma Surgery Center in about 20 years ago, and he did it because originally he thought, all these Canadians who are waiting to have surgeries done, they'll they'll come to my surgery center, have it done at a good price,
Mm-hmm.
and have a good outcome. And so he was the first person to post. If you go to their website right now, you can see all the pricing right there
Yeah.
for everything they do. Oklahoma Surgery Center, the Surgery Center of Oklahoma.
Mm.
And so initially, yes, his first patients were Canadians who were sick and tired of being in pain while they're waiting for their surgery.
Mm-hmm.
But then, employers who are getting unbiased advice on how to manage their healthcare supply chains are sending their patients there,
Mm.
right? Sending employees there
Mm.
because it's a good value.
Mm. Okay, tell us what's the title of the book and where we can find it and when it's going to be available.
Sure. So it's called Fixing Healthcare: How Executives Can Save Their People, Their Business, and the Economy. It's going to be out probably late November,
Okay.
and it's going to be on Amazon and all the usual channels, and available in hardcover and paperback. But really, what's different about the book from I think other authors in my space is that it talks about the industry and the landscape and the architecture of the industry in a way that I don't think is typically covered, so that executives can make more informed decisions
Mm.
and stop being so frustrated by the lack of clarity.
How big of a business are we talking that would be like a good fit for what you do?
Uh, 200 to 10,000 employees.
It's a good range. We got to keep getting our employees up then. Got to keep pressing.
Yeah, I mean, we really wish I mean, in a perfect world, we would be so well operationalized that we could really be profitable serving small groups. And I would love to get to that place. But right now, where we are in our 7th year, we just have to try to stay where we can be profitable and really effective for our customers.
Very cool. Donovan, thank you so much, man.
It's been a pleasure.
Appreciate
Thanks
it.
for having
I
me.
could keep asking questions all day.
I like to do.
Yeah.
Let me know next time you're in town.
I appreciate you, man. All right, man. Yeah.
Likewise. Take care.